Okay. Okay. So we are going to start with family medicine. So the first thing you need to know is we have in family medicine is the periodic health examination. What is periodic health examination? It is an examination that is done like not on the annual basis, according to the patients, like if they are coming on after 3 months, 4 months, 5 months. So it is not the annual examination. If you people live in Canada, most of you would be aware that over here, what we have annual physicals. The GPs are family physicians, they call us annually to do the annual physicals. But instead of those are not the recommendations. What the recommendation is, we have to do the periodic health examinations, that whenever a patient is visiting the doctor, there are few things that the doctor has to check along with the patient. So if you get any question, any MCQ regarding what is more effective way of preventive health, so we have to choose periodic health examination instead of the annual physicals. It has a superiority as compared to the annual physicals. Then in periodic health examination, what do we have? We have primary prevention and secondary prevention. You people can see my screen, right? I'm sharing it. Anybody
Yes.
can? Yes. Okay, fine. Sorry, I forgot to ask about it. Okay, so what we have in primary prevention and secondary prevention. So what is primary prevention? Primary prevention is all the methods like to prevent the disease, like vaccinations in children, counseling the patient about to prevent the risk factors, to work on the risk factors is the primary prevention. And how can we do that? We can have a proper immunization program, a proper vaccination program. This comes under primary prevention. Then we have secondary. What is secondary? It is early detection of the disease, all the screenings. The screenings we do like pap smear, like mammography, to prevent the disease before it occurs. What is that? That is secondary prevention. But once the disease has occurred, then that is not secondary prevention. Once we have the disease, then the next step is tertiary prevention. And what in that we do? We prevent the further progression of the disease, to prevent any rehabilitation. So the proper visits, like in case of diabetes, in tertiary prevention, what would be the like annual visits, ophthalmology visits, those will be tertiary prevention in diabetic patient. Similarly, before primary prevention, we have primordial prevention. And what comes in primordial prevention is like educating the people about the health, different ways they can implement in their life to prevent the risk factors, like educating the people. So we will discuss this more in public health. We have all like primary prevention, primordial, secondary, but basically you should know what in family medicine, what is primary prevention and what is secondary prevention. And always remember, screenings are only done before the disease has developed. Once we have a disease, then we do not do screening. What do? We do diagnostic testings. So in this periodic health examination, what should we know from this table? We should know that all of these A's, just remember the A's. All the A's, I have highlighted them. Remember these A's. If you remember the A's, it would be easier for you to remember the B, because you will know that, okay, it was not a part of A, so it must be B. What we have, like in a general population, these periodic health examinations are for the general population. So when they come to us, what we have to discuss with them? We have to discuss with them about their dental hygiene. It is very important, like community fluoridation, brushing, flossing. For us, we might think that, okay, dental hygiene is not something really important to discuss with the patient, but it is a part, and it is highly recommended that all the physicians, they discuss this with their patients. So what do we have over here in discussion? We have to discuss about dental hygiene, about noise control and hearing protection if they are working in high noise areas or high populated areas, because noise can have a lot of side effects. Yeah, effects on their hearing, other effect it carries. So we have to rule out those also. Then what we have, if a patient is a smoker, So we have to counsel them on smoking cessation. Every patient who is a smoker and who is coming to us, we always have to counsel them about smoking cessation. We cannot force them, but what we have to do, we have to first counsel them. So if they agree that, okay, I am ready to quit smoking, then we will move on to the first next steps. And then we can provide them with the nicotine replacement therapy. It's not that a smoker is coming to us and we'll just directly give him the replacement therapy and all the other pharmacological treatments. No, first we will counsel him. On every visit, it is necessary. It's not that on one visit he came and we counseled him, and on the next visit again we won't counsel. No, on every visit, if he's a smoker, we have to counsel him. Then in the special population, what we are going to discuss in pediatrics, home visits for high risk families. Okay, then in a perimenopausal woman, we have to assess their risk factor for osteoporosis and fractures, like any frequent falls, any other previous fractures. So we have to assess that in them. Adults above 65, on follow-up on caregiver concern on cognitive impairment. What the family members might come up and they say that, okay, our father, our mother, grandparent, they are, we feel that they are, they have some cognitive impairment. They forget things frequently, because a person who will have cognitive impairment, he himself won't be able to recognize it that much. So a family member might come up to you and they would like you to assess that patient. So on the request of the family member, we will assess the patient. There are some tests we have to do and carry to assess where the patient stands. Then we have to also assess for post-fall assessment, like multidisciplinary post-fall assessment. So all of these are in, they come under A, like we have to discuss with these people whenever they visit us. Then in physicals, what we are going to do in every visit, we have to measure blood pressure of all the patients who are coming to us, irrespective of their blood pressure measurement, whether they are hypertensive, diabetic, no, just a normal person without any previous health issues, we have to measure their blood pressure. Similarly, in children, if a mother is bringing up her child, neonate, during the first visit, however, every time the neonate is going to come, we have to do their hip examination, eyes and hearing examination. Then also in the high risk population, if we know that somebody has traveled from a high risk area where a TB is common, or indigenous people here in Canada, in First Nations or in some indigenous communities, what we still have TB is common in them. So if somebody is coming and traveling from that area and they are giving the symptoms, then we have to do the skin test to rule out TB in them. Similarly, in high-risk patient, like people with multiple sexual partners and high sexual behavior, homeless, what are they? They are high-risk groups for STIs. So we have to do antibody HIV screening for them, gonorrhea, syphilis screening. We have to do in this. We won't do it in everyone, only the high-risk groups. We have to perform them whenever they are coming to us. Then in journal recommendations, what are the excuse me, medications we are going to start? Every woman of childbearing age who is coming up to us, we have to start her on folic acid, whether she is sexually active or not. But if she is in the childbearing age, we have to start her on folic acid. Similarly, if the patient is hypertensive, we have to start them on pharmacological treatment, depending upon the guidelines. What are the guidelines? We're going to discuss them further. Then similarly, 1 to 12 years and adolescents who are susceptible to varicella, we have to give them varicella vaccine. Similarly, tetanus vaccine, which needs a booster every 10 years. If someone who hasn't got the booster for it, we have to recommend them that you need to get a tetanus booster. Similarly, for pertussis, adults less than 65. And what over here in a special population, in pediatrics, we all know routine immunization is a very must. Suppose a parent is coming with the kids and they say that, okay, we have to always ask about the immunization. If they say that the kid is not immunized, so first we have to ask the parents about the barriers. Why? What is the concern that is preventing them from getting the child immunized? We have to address those, and then according to that, we cannot force them, but we have to counsel them on every visit. Whenever they come, we will counsel them. And if they we will not force them, but we do recommend it to them. Then influenza, annual vaccinations in high risk population. What are the high risk populations for influenza? Same like for pneumococcal, like immunocompromised, age above 65, COPD, asthma, congestive heart failure, asplenia, liver disease, renal failure, and diabetes mellitus. What are these? These are the high risk group for which we are going to recommend annual pneumococcal vaccine and influenza vaccine. Okay, so similarly, we should know all these A's, because suppose if an MCQs come and they ask us that what is the most important thing we are going to discuss with our patient on a periodic health examination, and they might give us like noise control and hearing protection, one of the options. One of the option might be physical activity, other is screening about drinking or counseling against STIs. So if we know that noise control and hearing protection is more important than physical activity, then we will choose A. Because if we don't know this, then most of us might think that, okay, counseling the patient about physical activity might be more important, or counseling against STIs. No, what is more priority over here is the noise control and hearing protection. So just to make your life easier, just learn, or whatever way is you have of learning, just try to remember or memorize these A points. Okay, then we have the screenings. Very, very, very important. Every one of us might get 1, 2, 3 questions from screening. They might be a different, but we do get. So for breast cancer, what is the recommended screening guidelines? Women age 50 we start screening at in general population we are talking about. We are not talking about these screening guidelines in high risk patient. So these are general population. What are we doing? Age 50 and we stop at 74. And what is the screening we do with? We do with mammography every 2 to 3 years. They can give you an MCQ like a patient is here and she got her mammography done last year. No, but she's again concerned that she wants to get another mammography done. So we can tell her that no, you do not need another mammography for the next 2 years, because your previous mammography was fine and a year ago, and it is not recommended to have another mammography in next until and unless she has any symptoms. If she doesn't have any symptoms, we will not repeat it within 2 to 3 years. Similarly, for lung cancer, what is the screening guideline for adults age 55 to 74 with 30 or more pack year smoking history, who currently smoke or quit less than 15 years ago? Recommend annual screening. How do we screen for lung cancer? We screen with low dose CT scan and up to 3 consecutive times. So we do annually and up to 3 consecutive. Suppose we started for a patient at age 55. We did one screening at 55, low dose CT scan, it was normal. We did another one at 56, normal, another at 57. So he had 3 consecutive normal CT scans. So we're going to stop. We're not going to continue doing it annually every year. No, if he has 3 consecutive normal low dose CT scans, then we're going to stop. And we should know how to calculate the pack year history. It is not 30 years. It is 30 pack year smoking history. And how do we calculate that? We calculate it by the number of packs per day multiplied by number of years. Suppose if patient is coming to us and he is at 50 years old, right? And he says that I have been smoking for the last 15 years, 2 packs daily. So what is his pack year history? 15 multiplied by 2. So it will make 30. So in that basis, we are going to start his screening at 50 years. So it depends upon the number of pack years history also. So we should know that how to calculate it, because in the MCQs or CDM, they will not tell you that he has a 30 pack year history. No, they will tell you that he or she has been smoking this much cigarette for this long year. So that when you're able to calculate it, only then you can tell that, okay, is low dose CT scan recommended for him or no? Or maybe he has to follow up next year, after 2 years, when the back year history is appropriate according to the guidelines. Then we have colorectal cancer. For colorectal cancer, what is the normal screening guideline in normal population? We start at age 60 and stop at 74. Okay, just to make your life easier, remember, for all these breast cancer, lung cancer, and colorectal cancer, just remember that the screening stops at 74. And sometimes we get confused, oh, which one was at 60, which one was at 55. So I had a simple method, how I remembered. I used to forget it, but then what I remember, always remember breast is first, right? First comes the chest, then inside the chest we have the lungs. So first is chest, so 50, 55, and for colorectal, 60, it is down. So if you remember like this in a pattern, you won't forget it. 50, 55, and then 60. And all three of them are stopping at 74. After 74, we are not screening them. So what is the screening guideline for the general population? We are starting at 60. And what are we screening them with? We are screening them with FIT test or FOBT every 2 years. Or if we are doing sigmoidoscopy, then it is every 10 years. We do not repeat sigmoidoscopy before than 10 years. Then what in this table, we have the guidelines for the high risk population. If they have a family history, like men and women, if they are symptomatic, they come with the symptoms of cancer, like bleeding per rectum, constitutional symptoms, stomach aches, any family history. Then what are we going to do? Pencil-like stools. What are we going to do? Directly to the diagnostic workup. At that time, we are not doing any screening. But if any man or woman in the history, they tell us that they have a positive family history, regardless of any symptoms, they are asymptomatic, having a normal life, but they have a positive family history for colorectal cancer, then their screening guidelines would change. How does it change? For if they have a family history of HNPCC or FAP, first, what we are going to do, we have to always do genetic counseling. If any patient comes with a family history of anything, which can run in families, like a patient coming with a family history of cystic fibrosis, a patient coming with a family history of thalassemia. So in all those cases, what we always have to do genetic counseling. If they want to become pregnant, if they want to carry out their family. So whatever disease runs in a family, and the patient is coming to us, we always have to do genetic counseling in them. It's not just for colorectal cancer. Then what are their screening guidelines? For HNPCC, what we do at the start at age 20, and every 1 to 2 years, we are screening them with colonoscopy. And remember, this if suppose the family member had HNPCC, at age 20, so when will the screening of this patient begin? It will begin at age 10. So whichever comes first. If the family member had HNPCC at, let's say, at age 35, okay? So 10 years younger than 35 is 25. But for him, we won't start at 20. We will start at 20. Similarly, it all depends upon whichever comes first. If they had a family history at 25, then we will start at age 15, and we will do this colonoscopy every 1 to 2 years. Then for FAP, we are starting at age 10 to 12, and we are doing annual sigmoidoscopy. Okay, now here, remember, we are doing annual sigmoidoscopy because they have a family history. They are high-risk patients. But in general population, starting at age 60, what are we doing? We are doing sigmoidoscopy every 10 years. Similarly, for AAPC, when are we doing colonoscopy? Annually, begin at age 16 to 18. Now, for FAP and AAPC, it is irrespective of whatever age the family history is. We will start at 10 to 12 and 16 to 18. But for HNPCC, either age 20 or 10 years younger for the family member who had the history. Similarly, for if one first-degree relative with cancer or adenomatous polyps at age less than 60, or two or more first-degree relatives with polyps or colon cancer at any age, what will we do? We will do colonoscopy every 5 years. And when will we begin this colonoscopy? We will begin at age 40 or 10 years younger than the earliest possible case in the family. Same like this, HNPCC. Here we are beginning at age 40, whichever comes first. If the family member had at age 40, then the patient screening will start at 30 years. Then if the first degree relative with cancer or adenomatous polyps affected at age more than 60, or two or more second degree relatives with polyp, then the screening is going to start at age 40. Then one second degree relative or third degree relative affected, average risk screening at age 50. And if the patient comes to us and on we did a normal colonoscopy, or he's a high risk patient and we did colonoscopy, and on colonoscopy, what did we find? We found tubular adenomas. Then depending upon the size of the tubular adenomas, like if it is less than 1 centimeter, we will do colonoscopy in 5 years. If more than 2 adenomas, colonoscopy in 3 years. Incomplete examination, numerous polyps, advanced adenomas, malignant or large sessile adenomas, colonoscopy after a short interval based on the clinical judgment. So over here, what questions can they give you? They can give you a mother is coming and she had a history of FAP. She has a 12-year-old child. She's bringing him in for the first time. So what is the screening test we're going to do in the child? So we will say we'll start sigmoidoscopy now, because the child is already 12 years. And if he hasn't had any sigmoidoscopy done before, so we will start immediately. Similarly, they will give that one of the a boy comes in or a person comes in, he or she is maybe 30 years old, and one of his first degree relatives, his father had a history of colon cancer. And at what age? He had colon cancer at age 50. So when will we start screening in him? So if the father had a colon cancer at age 50, so when will we begin? When he, yes, at 40. So we'll tell him that, okay, we'll start colonoscopy every 5 years at age 40. Okay. Yes, I'll answer your questions, but in the end, because I'm recording this session, so I don't want this to like, we'll just record it, and then in the end, I will answer all of your questions. Is that okay?
Yes, fine.
Okay, thank you. You can keep writing the questions in the chat so that you don't forget. And then in the end, we can answer them together. Then we have cervical cancer screening. So what is cervical cancer screening? We are starting at age 30 and stopping at 69. Okay, one thing I want to address, this screening guideline in Toronto notes 2022. I have not seen the 23. If anybody has, they can share it in with the group so that everybody can benefit it. This screening guideline has changed. Last year in March, the guidelines were changed. So now what do we need to do? We need to follow the latest guidelines, because this exam is all about the latest, what they are following in the system. So if any question comes about the latest guide, like about cervical cancer, we should have in our mind that, okay, we have to follow the latest guidelines. And the answer would be, I will share the latest guidelines in the group. So I should have shared them, but I'm sorry I didn't share them, but I'll share them after the class. So don't try to follow those, okay? So whoever is sexually active, a female, she is sexually active, even she has been sexually active once in her life, she comes to you, we have to do pap smear every 3 years. It is not that, okay, a woman comes to you and she said that I was just sexually active once, like in my 13, or it was just a one, I just had it by mistake and now I'm not sexually active. Even then, we will carry out pap smear every 3 years on that patient, okay? So, and if a woman comes to you, she's 40 years old and she says that I'm unmarried, I'm virgin, I've never been sexually active, though she's 40, 50, 60, whatever her age is, she is not recommended for pap smear. Pap smear is only done, the cervical cancer screening guidelines are only applied for the women who are sexually active. Remember that. If she is not sexually active, no screening would be done in her. And then based on this, what we have to do, if the screening is normal, what will we do? Sorry. We will repeat in every 3 years. But if a patient comes up to us and we did the screening, and on the screening we found ascus, what we are going to do is that then we have to repeat the screening. We have to repeat it according to the latest guidelines. We have to repeat it after 6 months. And then again after 12 months, and it goes like that. I'll share those and just learn those guidelines. Then after how many time we have to repeat the screening. I'll share the screening, the latest one, in the group, and then tomorrow we can also, I'll just quickly go through it, because I don't want to go through this old screening guidelines and then you guys will be confused. So it's better that we just follow and study the new one. But just remember, if a woman is sexually active, even if she had been active once, even if it was a case of a rape or abuse, she will go screening every 3 years. But if she has never been sexually active, then no screening for her. Prostate cancer, we do not screen for prostate cancer. This is like, I don't know why they have given it, and it is so confusing. Every time the doctors always ask, do we screen, do we not screen? So just remember, there is no screening for prostate cancer. We do not screen it because the harms are more than the benefits. So we do not screen. Just remember, there's no screening. So they will either ask you like a question, a male is coming, he's 40 years old, 50 years old, he has this, so are we gonna, in the screening guideline, they will give us different options. So if prostate cancer is there, we are not gonna choose it. We are not screening for prostate cancer in normal population. Then next is the health promotion and counseling. What comes under health promotion and counseling? This counseling, the motivational counseling, is done for people like who are smokers, who are alcoholic, who are obese. The ones who want, we do that to change their behavior. A smoker, he wants to quit his his smoking. Similarly, someone is obese and he wants to reduce his weight. So in all these people, what we do motivational behavior strategies we apply. And what are these? We start with pre-contemplation. And what is pre-contemplation? In this, if we assess whether the patient is ready to change or no. Okay, assess his readiness, whether he is aware of what he's doing. Is it harmful? What are the health effects on it? So we just, in pre-contemplation, a patient is coming to us and we assess how ready he is for the change. After that, what comes? The contemplation. In contemplation, what are we going to do? We are going to encourage him. If a person comes to us and he says that, yes, I know, doctor, I smoke and it's not good for my health, but I've never tried anything. So he is in that phase. He understands the advantages and disadvantages, but he didn't proceed to the next step. So what we can do, we can motivate him in this step. We will motivate him. Then how will we motivate him? Next step is we're going to prepare him. How will we prepare him? By exploring options and choose course most appropriate for the patient. We're not just going to give him one option and we're going to tell him, okay, this is the option and you have to. No, we're going to discuss with him, and whichever option he chooses, then we're going to go with that. Then the action. Help patient design rewards for success. Then develop strategies to prevent relapses. We're going to inform him that it is a difficult pathway, but there might be relapses. People do relapse back, but so that he's aware. Once he's in the process, he's aware that, okay, relapses can occur and how he can prevent them. Support and reinforce convictions towards long-term change. And yes. Okay, then what will we do? Maintenance. Help patient maintain motivation. review identified high-risk situations and strategies for preventing relapse, increase self-belief and ongoing change. So what are we going to do? With regular follow-ups, we are going to check whether the patient is maintaining what he started. He is following the steps or not. Discuss progress and signs of impending relapse. Then in relapse, help patient view relapse as a learning experience, provide support appropriate to re-entry into the change cycle at the patient's present level of readiness. And sometimes the patient might come to you and he says that I have tried 2 to 3 times, but again, I relapse. So then how will we start? We will start from relapse to pre-contemplation. Is he ready to start again from the beginning? Then we're going to help him. So it depends on which stage the patient is coming and how we are progressing to the next stage. Sometimes the patient might come to you, they're all prepared, they have all the plans, everything with them, and they just want some motivations or next steps or follow-ups with you. So it depends on which stage he is coming and how we are motivating him. Okay, on the side, yes, this is important. We should know that vitamin D, it is recommended by the Cancer Society of Canada for what? In prevention of colorectal cancer and breast cancer. So vitamin D has a role in the prevention of both colorectal cancer and breast cancer. And what other things are helpful in prevention of colorectal cancer? It's aspirin and high fiber diet. Maintaining a good weight. So these are preventive measures for colorectal cancer. Okay, then this is the normal nutrition guidelines, what we should eat. It is like high quality food, and this is important. This plate is important. How we are going to remember this is that what the Canadian food guidelines are, that we are going to divide our plate in 2 halves, and the 1 half we are going to divide it in further 2 halves. So 1 whole half is going to be fruits and vegetables, and the other half, 1 part is going to be protein, and the other part is going to be fine whole grains. Okay, so just remember it like this. And then we have to drink plenty of water and use oil, that is olive and canola oil are recommended. We should just know that what is the food guidelines. So you should know that we divide it into 3, and half is fruits and vegetables, and the other 2 are protein and carbohydrates. And which diet is recommended for a normal population? Mediterranean diet. Remember that Mediterranean diet is for the general population. But if somebody is diabetic, hypertensive, then DASH diet. We always recommend them to follow DASH diet. Okay, then we have obesity. Okay, what we have in obesity is that we should know what are the risk factors, what is the BMI that leads to obesity. So in epidemiology, obesity remains higher in population which face multiple socioeconomic barriers, such as geographic isolation, poverty, and lack of access to nutritious food. For example, First Nations living on reserve have higher rate of obesity than non-Indigenous people. We should actually, for obesity, we should know who do we have to screen. Like if they give us an MCQ and they say an Indigenous or First Nation patient is coming to us and woman, and she's perfectly fine and healthy, what is the things we are going to screen them for? So obesity is one of the things. We screen them for in these people, what is high? Obesity is high. In them, what is high is depression is high. We screen them for depression. We screen them for obesity, for diabetes, for abuse. These things are very common in Indigenous population. Then next is for appropriately healthy adults 18 years or more, it is recommended to measure height, weight, and calculate BMI at appropriate primary care visits. So whenever 18 years and above they are coming, we will calculate their BMI. And according to the BMI, if the BMI is normal, fine, we'll go normally with the visits. But if the BMI is high or low, then we have to further assess that what is the cause of low BMI and what is the cause of high BMI. If the BMI is more than between 25 to 34.9, less than 35. So 25 to less than 35, what we are going to do, we have to measure their waist circumference. Now here we should know that BMI underweight is what? 18.5 or less. That is underweight. And then it means that there is some problem. Maybe they have some eating disorder, some other nutritional deficits. So we have to further screen it, further assess it to check what is going on. Similarly, if a patient is coming, they have the BMI is normal, it's okay. Normal examination, BMI is normal, nothing to be assessed. But if the they are on the obese side, if they have diabetes and their BMI is more than 30, then we have to assess them. Okay, on this is just the same motivational, what we are going to, if the patient obese, how will we start them? We will first start them with, I think this had a table. Yes, we'll do this table. Everything in the table over there is summarized in the table. So how we're gonna do this table. Okay, so if a patient who is overweight and obese, first we're going to measure their BMI. Then if the BMI is more than 25 or less than 35, we're going to measure their waist circumference. If the BMI is more than 25 or the waist circumference is above the cutoff value, then what we are doing, we have to conduct some tests in these papers. What are those tests? Blood pressure, heart rate, fasting glucose, lipid profile. What comes under lipid profile is total cholesterol, triglycerides, LDL, HDL cholesterol, ratio of total cholesterol to LDL cholesterol. All of these things come under the normal investigations we are going to perform in this population. Then we are going to, whenever obese, remember this screening is important. If a person who is coming to us and he is obese and we just start all the investigation and start them on diet and start them on all the pharmacological therapies, and we do not screen them for the underlying cause, we always have to screen them for depression, eating, and mood disorder. Maybe they're obese because they're depressed. Maybe they have some mood disorders or some eating disorder. So we always have to first screen them for that. And if any of this is present, then we have to treat them for this disease, this comorbidity first, rather than starting them on a diet and weight loss goals and lifestyle. No, because this is the cause. So always remember, first treat the cause. And always, even if it's a teenager who's coming to you, who is obese, maybe they are depressed, we always have to ask them about if they are getting any bullied at school. Because over here, bullying at school in teenagers, bullying and like obesity, they are related together in many cases. So always, if they give us a scenario and they say that it's a teenager, he's 16 years old or 17, he is here for his obesity, he wants to lose weight. So we have to first screen him. Are you suffering any bullying at school? Okay, do you have any depression, any eating disorder? These are the important things. Then if there is comorbidity present, we have to treat it first. After that, we are going to assess the patient whether they are ready for the change or not. The same motivational interviewing. We're going to ask them all the steps. We are going to see, according to the patient's behavior, whether they are ready or not. And if they are not ready, then what is the barrier? What is the cause that they do not want to lose weight? Then how will we start? We will start with a weight loss goal should not be more than 5 to 10% of the body weight, or 0.5 to 1 kg, which makes 1 to 2 pounds per week for 6 months. So the weight loss goal should not be more than this. Remember, they might give you an MCQ or might give you a CDM question asking you, okay, what is the weight loss goal for this patient? He's obese, his BMI is this, you have started him on lifestyle modification, and what is the weight loss goal he should be achieving in the next 6 months? So it is per week, 0.5 to 1 kg. Whichever you can, 1 to 2 pounds or 0.5 to 1 kg, you should know this figure. It is important. Then what is it? Then we are going to connect the patient with different social workers, with different health teams, advisories. And in lifestyle modification, along with physical activity, we are doing nutrition. And what does nutrition is? Reduce energy intake by 500 to 1000 kilocalorie per day. Along with that, we will encourage the patient to have a physical activity of 30 minutes of moderate intensity, 3 to 5 times per week, eventually more than 60 minutes on most days. Add endurance exercise training. And along with this, we are going to do cognitive behavior therapy. Okay, so suppose if a patient comes to us and she's saying that she's on the obese side and she wants to lose weight, and she says that I exercise 20 minutes every day, like for 5 times a week. And her nutrition is like she has reduced it to 500 to 1000 kilocalories per day in the past 3 months. So what is the next step? We will ask her to increase her activity. The physical activity should be according to the recommended guideline. If she's doing 20 minutes, we have to first tell her, no, you have to increase it. You have to increase it to at least 30 minutes. Okay. And then eventually to 60 minutes. So if they're following all the other things, but one thing is less, then we first have to improve or work on that thing. And then even after doing all these things, the goal is not achieved, they are still obese and their weight is not reducing, then what are we going to do? We are going to go to the pharmacotherapy. If they come and we are assessing them and they're losing weight and everything is going well, then just continue lifestyle modification and then just regular follow-ups. And on each follow-up, what are we going to do? We are going to assess them for weight, BMI, waist circumference on every visit. So just to have a proper follow-up. But if it is not working, then we will move to pharmacotherapy. And who are we going to move on with? That is BMI more than 27 and risk factors, or BMI more than 30. What are the risk factors? Risk factors are like somebody is diabetic, somebody has some heart disease. So if in these patients, the BMI is more than 27, in them at this BMI, we can start the pharmacotherapy. But other than that, if a person is coming, he is obese and he has tried all the nutritional and lifestyle modifications, but his BMI is more than 30, still more than 30, he has no other comorbidity, then we are going to start him on pharmacotherapy. And what are the pharmacotherapies we use? We use 3 drugs. They are mentioned here. Let me show you. Yes. What do we use? We use naltrexone and bupropion. We use liraglutide, and we use orlistat. So these are the 3 drugs. Any 3 of them we can use for obese patient. Then it depends. The most the popular that is used is orlistat and liraglutide. These are more commonly used. So what are we going to do? If with the lifestyle modification, still no benefit, then we're going to go to pharmacotherapy. After that, if the patient comes and he has been using pharmacotherapy for at least 6 months, along with lifestyle modification, all of these things go together. If he's just using the medication and he has stopped the pharmacotherapy, the lifestyle modification, then we do not proceed to the next step, remember, okay? So then after all this, then we are going to move to bariatric surgery. That is the last resort. And only in those patients who have BMI more than 35 with comorbidities, or BMI more than 40 or more without any comorbidity, then we are going to recommend them bariatric surgery, but it is the last resort and it is not done very easily. Remember, you are not, if they give you a scenario and they tell you that a patient is 35 years old, has a BMI of 35 and she is diabetic and she is here for bariatric surgery, we are not immediately going to start the patient on bariatric. We're not just going to recommend her. No, we're not going to refer her to the bariatric surgeon. No, what we are going to do, we will start from this. Okay, at least 6 months of this lifestyle modification. Then after that 6 months, in this bariatric surgery, there's a proper protocol which they follow. They assess the patient, and if the patient is missing even one of those steps, they would not recommend bariatric surgery. And even after this bariatric surgery, there are lots of follow-ups and different things. It's a lifelong process which the patient has to follow. And if the patient is ready, then they recommend it. So it's the very last resort. So even if the patient is first time coming with a BMI of this, first we will start with lifestyle modification, exercises. We're going to assess them along with cognitive behavior therapy. Then not working, go to pharmacotherapy. Then after that, they assess And in the end, bariatric comes. Okay, anything? Yes. And similarly, we should know that if the patient is coming with low BMI, so what are the risk factors of low BMI? Those are osteoporosis, eating disorder, undernutrition, pregnancy complications. Okay, low BMI, it is also very important in this. We have anorexia nervosa and other nutritional eating disorders. We're going to discuss those come in psychiatry, but we should know this triad. This triad is very important. Osteoporosis, eating disorder, and what is osteoporosis leading to? Fractures. Okay, so the patient might come up to you with fractures. In nutritional deficiency, they may come up to you with amenorrhea. A female, a young female, 20 years old, she's presenting to you with amenorrhea for the last 3 months. Along with that, because people who have eating disorder, they won't just come up to you and tell you they have a eating disorder. So they will give you some of, she has a history of fracture in the past 2 months. So what is the cause of all this? They might ask you, what is the cause? The cause can be low BMI due to some eating disorder. We're going to discuss this later on. Okay. Then we have dyslipidemia. Okay, in dyslipidemia, yes, this table. If you know this table, then you know what is it, because this table is explained. It is all elaborated over here. So we'll go through the table. Okay, first of all, we should know that they will not ask you to calculate the FRS score, but you should know that at what percentage we are starting the patient on medications, or at what score we have to do lifestyle modification. Okay, first, what are the signs of dyslipidemia? What is dyslipidemia? It is high lipid levels, right? So what are the signs? The patient might have signs of atherometa, that is plaques in the intimal layer of the arterial wall. Then xanthelasmata. These are yellowish color deposits, mainly in the eye, in the skin areas, eyelid areas. Tendinous xanthomas, lipid deposit in the tendon. Eruptive xanthomas, hypertriglyceridemia, induce reddish, yellow, pruritic, and painful papular or nodular rash. Lipemia retinalis. And what is lipemia retinalis? Characterized by creamy, white-colored retinal blood vessels, occurs only with extreme hypertriglyceridemia. And corneal arcus, lipid deposits in cornea. So these are the signs of hyperlipidemia. But patient won't present you with these signs. How will we know that the patient has hyperlipidemia? He maybe on the basis of the blood test or some other test. Like sometimes this xanthelasmata, they are hereditary. So if a person is presenting with this yellow deposits on any part of their skin, then we have to screen them for hyperlipidemia. Then what are the risk assessments? FRS score or cardiovascular life expectancy model. Repeat screening every 5 years for FRS less than 5%, or every year for FRS more than or equal to 5%. So depending on the FRS score, our screening is also changing. If the person's FRS score is less than 10%, they are at low risk, and we will not start them on any medications. How will we start? We will start with a proper diet plan, exercise, all these things. In primary prevention conditions, intermediate risk is FRS 10 to 19% and LDL cholesterol more than 3.5. We should remember that the LDL, the level of LDL should be less than 2. That is the recommendations, okay? So if it is more than 3.5, then it means that the patient has hyperlipidemia. Similarly, non-HDL more than 4.3, ApoB more than 1.2, and men more than 50, and women more than or equal to 60, with one additional risk factors, all of which are given over here. So, and what are the high risk? They are FRS more than 20% or more. So they are high risk. Less than 10%, low risk, no treatment, just lifestyle modification. Above 20%, high risk, we will start them on medications. And in between, intermediate risk. Then statin-induced conditions. What are the statin-induced conditions? Clinical atherosclerosis. If a patient is presenting with abdominal aortic aneurysm, diabetic patient with age above 40 years, age above or equal to 30 years, and 25 year of duration of type 1 diabetes. They may be diabetic and they might be coming with any complications like chronic kidney disease or microvascular complications. In these patients, we are immediately starting the medications. Similarly, if the LDL is more than 5 or more than 5, then it is genetic dyslipidemia. So genetic means it runs in families. So we have to also start them on medication. So what are we doing over here is that discuss behavioral modifications. And what are if the patient is a smoker, first of all, we have to counsel them to stop smoking for dyslipidemia. Always remember that if a patient is presenting with any of these conditions, like we discussed obesity, we're going to discuss lipidemia, hypertension, diabetes, always we have to first start with lifestyle modification. We are not immediately going to jump onto the pharmacological therapy. No, first start with lifestyle modification, assess the patient, and then we go to the next step. So we start with smoking cessation, excluding some special circumstances. Otherwise, always with lifestyle modification. In diet, adopt a healthy dietary plan. Exercise for at least 150 minutes per week of moderate vigorous aerobics. Then, what do we do? If the patient has not achieved the level with these lifestyle modifications, we are going to go to statins. And then, if we have started the patient on statins, and the LDL cholesterol has been like it reduces to less than 2 or APO less than point. They mostly ask about the LDL cholesterol. Okay, or more than 50% reduction of the cholesterol level from the baseline. So we are going to continue the same treatment. But however, if it has not been achieved, and we have the statins, we have even increased the dose to the maximum level, then what we are going to do, we are going to add another therapy. With statin, we are going to add another one of the pharmacotherapy. But if the patient, we started the patient on a low dose of statin and the targets were achieved, we are going to continue on the same dose. If on that initial dose, the targets were not achieved, and on the next follow-up, the level of cholesterol was still high, what are we going to do? We are going to increase the dose of the statin until the maximum cutoff point has reached. Okay, and if at that level, the levels of cholesterol are normal, they have reduced, then we will continue on at that dose. But if still the levels have not decreased, what will we do? Then we will either add ezetimibe. It is the first line we add. After that, what is the second line? PCSK9 inhibitors. Okay, or we can add both of them together. So it all depends upon what the patient is presenting with, but mostly with statins, the first line is ezetimibe. Okay, and what are the risk factors for? Okay, what are the risk factors for screening for dyslipidemia? The risk factors are men and women age 40 years or above, or postmenopausal. So if a normal person, normal screening, no health issues, so at what age we start screening for dyslipidemia? At age 40. If a person has no risk factors and everything is normal, we do not screen before 40 for them. Similarly, increased incidence in indigenous individuals or individuals of South Asian ancestry. Current cigarette smoking, type 2 diabetes, arterial hypertension, family history of premature cardiovascular disease, family history of men less than 55. It means less than 59 means at 54, sorry, and female less than 65 in first degree relatives. So what are first degree relatives? Mom, dad, and brother and sisters. These are the first degree relatives. Then family history of dyslipidemia, erectile dysfunction, chronic kidney disease, inflammatory disease, that is lupus, rheumatoid arthritis, psoriatic arthritis, IBD, HIV infection, COPD, clinical evidence of atherosclerosis or abdominal aortic aneurysm. Then if the patient is presenting with any signs like he has arcus cornea, then xanthelasma, xanthomas, or he's obese, BMI is more than equal to 30, hypertensive disease of pregnancy. So in these people, we will screen for dyslipidemia early. Suppose they might give you a CDM question in which they will ask you that, okay, a 30-year-old smoker of South Asian 30-year-old male is here for his regular follow-up. What are you going to screen him for? Now, although he's 30 years old, but he's high risk. Like what? He is South Asian. He is smoking. Where it is gone. Okay. And yes, he's smoking. He's South Asian. So these two are risk factors, right? So we are going to screen him for dyslipidemia. They might ask you, okay, what is the screening we are going to do? Or are we going to screen him for dyslipidemia, true or false? So we have to screen him because he is a high risk population. Similarly, a person who of 35-year-old might come to you and he says that, oh, my mother had dyslipidemia, had an MI attack at the age of 60. And I have a family history of dyslipidemia. Then we are going to screen him for at the age of 30, 35. If they have any of these risk factors, but they them are asymptomatic, perfectly fine. We have to start screening even at an earlier age. Okay, then how do we screen? We screen with full lipid profile every 1 to 3 years in male and female above 40 years or more. So 40 years or more, normal population, we start screening with full lipid profile every 1 to 3 years, or who are menopausal or at any age for adults with additional dyslipidemia risk factors, what I just mentioned before. And in the late postpartum period for women who have had a pregnancy-related complication, for example, hypertensive disorder of pregnancy, gestational diabetes, preterm birth, stillbirth, low birth weight infants, and placental abruption. Then we're going to take their history, physical examination, and what is the standard in lipid panel? What do we check? We do total cholesterol, LDL, HDL, triglycerides, calculated HDL. And along with that, we also do their glucose levels. We do their eGFR. Okay, and how do we, for the risk factors, how do we calculate their cardiovascular age? It is calculated as patient's age minus the difference between his or her estimated remaining life expectancy and the average remaining life expectancy of Canadians of the same age and sex. And how do we manage it? Similarly, we did it in the table: smoking cessation, dietary modification, reduce saturated fat. What is in dietary modification is reduce saturated fats, red meat should be reduced, refined sugars, alcohol, all of these things should be reduced. Consume nuts, fruits or vegetables more, and poultry and fish. Then physical activity should be at least 150 minutes. Now, remember, for dyslipidemia, it is 150 minutes per week aerobic exercise. For obesity, what did we study? It was at least 30 minutes, 4 to 5 times a week. So this is the difference. For different things, the physical activity is also different, and you should know what is the for each comorbidity or each problem, what is the value. Employ consistent lifestyle modifications for at least 3 months before considering drug therapy. Then for pharmacologic therapy, we start them on statins. What are the risk factors of statins? It's myopathy, myalgia, rhabdomyolysis. If severe side effects, we switch on to ezetimibe. Then once we start the patient on statins, what do we do at baseline? Baseline means that before starting the medication, what we will check? We will take ALT, CK, and creatinine. Then 6 weeks later, we will assess the patient for any signs of transaminitis or myositis. How will he present? He might tell us that, okay, I'm having some aches and pains. We will assess them for that. And up to 10 times rise of the upper limit of if the patient does not have any symptoms, then we can wait for at least 10 times rise in the CK level. But if the patient, before switching the drug, but if the patient CK levels, they rise up to 2 to 3 times only, and he is presenting with a lot of pains and aches and symptoms of myalgia, then we have to switch the medication. So if he's asymptomatic and the CK levels are up to 10 times, we will tolerate it. We won't switch. But if symptomatic even at 2 times, 3 times, we have to switch the medication. Or serum creatinine rise of 25% or less. Then what do we do? If adequate response is achieved, evaluate fasting lipids every 6 to 12 months. And for these, when we start the patient on statins, we just repeat it at baseline and then after 6 weeks. If the patient is asymptomatic, everything is fine, then we do not repeat them again and again. Okay. Then what is isolated hypertriglyceridemia? Isolated hypertriglyceridemia is, what was the risk factor for dyslipidemia? It was coronary artery disease, one of the risk factors, cardiovascular disease. But if only triglyceride levels are elevated, everything else is fine, but only triglycerides are elevated, then it is not a risk factor for cardiovascular disease. In this, normal HDL and total cholesterol, only triglycerides are elevated. And what is the risk factors for hypertriglyceridemia? It is pancreatitis. So it is one of the causes of pancreatitis. In this, mild 2.2 or more millimole per liter, marked will be 5.6 millimole per liter or more. Principal therapy is lifestyle modification. In this also, look, we are starting with lifestyle modification. Weight loss, exercise, avoidance of smoking and alcohol, effective blood glucose control in those with diabetes, increased omega-3 fatty acid intake. Severe hypertriglyceridemia is associated with an increased risk of acute pancreatitis. Then drug therapy, in this, what are we giving? Nicotinic acid and fibrates. So this is the drugs therapy for isolated only hypertriglyceridemia. We are starting the patient on nicotinic acid and fibrates if needed. But in dyslipidemia, we are starting with statins. Then this is the normal the Canadian guidelines for exercise. What we should know in here is more important is that for children less than 5 years, like up till 4 years, what is the screening guidelines? It is less than 1 hour per day. And above that, for everyone, it is less than 2 hours. So they might give you a scenario in which they might tell you that the mother is bringing in her child and he's perfectly fine. And he plays outside, he does everything, he eats a normal healthy diet, and he has a screen time of 3 hours or 4 hours per day. So what are we going to then screen this child for? We're going to screen him for obesity. And what are the recommendations, and what will we recommend the mother to reduce the screening time to less than 2 hours per day? Okay. What are the benefits of exercise? The exercise reduces risk of premature death, heart disease, stroke, hypertension, certain types of cancers, type 2 diabetes, osteoporosis, overweight, and obesity. Leads to improved fitness, strength, mobility, functional independence, and mental health. Just a second. Do you people need a break of 5 minutes or is it fine?
It's such an effective and efficient session, I must say. That's
because we already know that adhesive capsulitis is related to some disease like it's more common in the diabetic patient, and this kind of repeated motion of the use of this shoulder joint. Okay, so it is any. Hello. Can you mute yourself? I think somebody is unmute. Okay, let's just start. Then we have smoking cessation. What do we have in smoking cessation? It's all that motivational interviewing. Always when a person comes to us, we have to counsel them on smoking, that you have to quit smoking. As a physician, family physician, it is our job to always counsel the patient on smoking. And then what are we going to assess in them? We are going to assess according tobacco use status should be updated for all patients regularly. Healthcare providers should clearly advise patients to quit. What our job is, we have to advise them. We do not have to enforce them. On every visit, we will just advise them. And if they are ready for the next step, then we will move on. Then healthcare providers should conduct regular follow-ups to assess response and monitor the patient's mental health status or other addiction while quitting smoking. Can you please all mute yourself? Then what are the medication doses should be monitored and adjusted as necessary. Every smoker should be offered treatment. Educate patient to watch for withdrawal symptoms. Okay, now when we are going to start, the patient comes to us and the patient says that, okay, I'm ready to quit. So we're not just abruptly going to start them that, okay, this is the therapy you're going to take and that's it, no, medication, you know. We have to always tell them, educate them that, okay, this is a different process. Once you're going to start it, what is going to happen is that you might have some withdrawal symptoms and you will have some low mood, insomnia, irritability, anxiety, difficulty concentrating, restlessness, decreased heart rate, and increased appetite. You always have to counsel the patient on that, and so that he knows that, okay, these symptoms are not new, they are part of my therapy. Just a second. So what are we going to do is that we're going to aware the patient of the withdrawal symptoms. After that, once we have made them aware, always remember that both the things go together. Cognitive behavior therapy, along with the pharmacological therapy, is the most effective one. The most effective way of counseling the patient or on quitting smoking is medication along with cognitive behavior therapy. And how many sessions are in the CBT? It is 4 or more sessions for 10 or more minutes, along with 6 to 12 follow-ups. Okay, and we are also going to provide the patient with some social support, some community resources. This is a very important topic actually for NAC also. Very important. If you, after this, whoever is going to, all of you are going to give NAC. So this is a very important topic for like how to counsel a patient on smoking cessation for NAC-OSCE point of view. Okay, in pregnant patient, first thing what is recommended is counseling. Patient, she is pregnant, she is smoking. We do not directly jump to the NRT. First, we will always counsel them. We will tell them the risks and the harmful effects on her pregnancy, on the baby, what it can do. And then if she's ready, we will move on to NRT. Always remember, it is the patient's choice, whether they want to quit, whether they want to take the pharmacological therapy, they want to just continue with the CBT. Here in Canada, you do not force anything on the patient. It is the patient's choice, and whatever we counsel them, but which option they like, we go along with that. Then intermittent NRTs are used, that is lozenges and gums, and they are preferred over the patches, because mostly the people, when they use patches, they do complain of some rashes or allergies. So these are more preferred treatment. Then what is the first line pharmacological treatment? We will always start the patient with NRT, that is nicotine replacement therapy. And after that, the second is the pharmacological. If we have started the patient on the NRT and still they were not able to withdraw and the cravings were not reduced, it did not help them, then the next step is we'll switch to either bupropion or varenicline, but always start with NRT. And what are the cautions we have to use? Immediately post MI, worsening angina, arrhythmias. If there are no contraindications, remember that, then we directly start with this. Advise no smoking while using NRT. And for NRT, what it is recommended that when the patient has started on NRT, he should not smoke, while this is not the case with this bupropion and varenicline. What is the, and where it is, yes, for bupropion, what do we do? For the first 1 week, he will continue to smoke. continue to smoke for first 1 to 2 weeks of treatment and then completely stop. So when we're starting a patient on bupropion or varenicline, we can tell them that, okay, for first 1 to 2 weeks, you can smoke so that they can slowly reduce and get into the pattern. And then after that, you have to completely stop. And what will this do? It will reduce their cravings. But for bupropion, it is an antidepressant. Always remember that if a patient has any seizure history, any epilepsy, any other seizure disorder, he has any eating disorder, he has been using monoamine oxidase inhibitors in the past 14 days, then we will not give him bupropion, or he is already on bupropion for some depressive disorder, any psychiatric disorder, then we will not give it to him. And what are the side effects? Side effects are insomnia and dry mouth. But if a patient for varenicline, what are the side effects? The most important side effect for varenicline is dreams, like nightmares. These people do have some very bad dreams. So we always have to dream disorder. We always have to aware the patient that, okay, you are going to take this medication, but one of the major side effect is dream disorder. So you should be aware of that. Okay, so side effects are nausea, vomiting, constipation, headache, dream disorder, insomnia, increased risk of psychosis, depression, and suicidal ideation. What are these? These are the side effects of varenicline. When I was starting the patient on any medication, always tell them about the side effects so that they are aware. And what are the red flags? Like, what is the limit of the side effects? If they are normal, they're having some nausea, vomiting, it's okay. But if it's beyond their reach, they cannot take it anymore, then they have to come back and we have to change the medication. Similarly, for prescribing, they have to decide on a quit date and then continue to smoke for first 1 week and then completely stop. And for varenicline, if already taking for any psychiatric condition, they have pre-existing psychiatric condition, we do not recommend it. So how do we start? First, counseling. After counseling, if they're ready, then NRT, then after that, if not working, move on to bupropion or varenicline. And along with that, what if a pregnant patient is coming to you, always start with counseling. They might tell you that, okay, primary gravida is here on her first visit, and she on the history, she tells you that she is a smoker. So what are we going to do? We are going to start her on counseling. And if she says that, okay, I'm ready to quit, what is the next step you're going to do? We are going to start her on NRT. And we always have to, what are the 5 A's for patient willing to quit? Ask if the patient currently smokes and is willing to discuss cessation. Advise the patient to quit, assess willingness to quit, assist in quit attempts, and arrange follow-up. So they might give you MCQ or CDM question telling that the patient is willing to quit, and you have given him all the advised him or told him about all the what are the different steps for quitting. What is the next step you're going to do? So what is the next step? Assess willingness to quit. We have discussed all the steps, the patient is willing, we have discussed all the steps. So what is the next step? Assess how much ready he is to quit. Okay, so this, like, we should know stepwise. Like, okay, if they give us, okay, we have assessed his willingness and he's all ready and all done. What is the next? Assess and quit attempts or arrange follow-ups. After all this is done, we have everything is done. What is the last step? We have to put the patient on regular follow-ups. Okay. Then we have alcohol use. For alcohol use disorder, what is it? Also for alcohol guidelines, they were given over here, but these are not the guidelines. Now I think, yes, this is changed. Now the recent guidelines are 2 drinks per week. So from 2 drinks per day or less than 10 drinks per week, it has changed to 2 drinks per week, and that is for everyone, for men, women. This is not the recent one. They changed it this year, and the recent guidelines are less than 2 drinks per week for alcohol. Okay, and remember, for everything, we should know what are the recent guidelines. Okay. Okay, then, okay, how will we assess if the patient has an alcohol dependence or no? According to the CAGE questionnaire. And what is the CAGE questionnaire? Have you ever felt you needed to cut down on your drinking? A person is coming up to you and he tells you that, okay, I drink. In the history, he gives you the history of drinking. Then how to know whether he is dependent on alcohol or no? We will ask him these 4 questions. Okay, and if he says yes to any 2 of these questions, it means that, okay, he is dependent on the alcohol. And then we will move on to the next step. So have you ever felt you needed to cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about drinking? Have you ever felt you needed a drink first thing in the morning? Like, is it when you get up in the morning, first thing you do is you drink, okay, to steady your nerves or to get rid of hangover. So if he is saying cut, annoyed, guilty, and eye opener, yes to any 2 of these, then it means that he is dependent on alcohol and we have to move on to the next step. And for next step, what will we do? Then we have to screen him. We have to do some investigations and we have to counsel him to stop smoking. Okay, identify positive. If identified positive for alcohol use disorder, then we always have to screen them for another. What if along with alcohol, they are taking any other drug, they're doing any other drug abuse, like they're using cocaine or heroin, opioids, anything. So we have to screen them for that also. Identify any medical or psychiatric complication. Do they have any underlying medical, like if they are using alcohol, they are dependent on that. So did they have any complications like withdrawal symptoms, like delirium tremors, any seizures, any hallucinations? Did they experience any of these? Then ask about, are they drinking and driving? Because drinking and driving is not allowed. And if they're doing that, they are drunk and they're driving, we have to report to the transportation authorities. Ask about past recovery attempts and assess current readiness to change. Then if a patient is coming and he is positive for alcohol use, then we have to, what investigations are we going to do? GGT, MCV for baseline and follow-up monitoring, AST, ALT. And remember, if they are giving you a scenario and they are telling you, they're giving you signs of, the patient has sign of cirrhosis and his AST is 2:1 from ALT, like AST is 2 times higher. If they are giving you, suppose AST is 60, okay, in the values, they won't tell you that AST-ALT ratio is 2:1. This is what we have to calculate ourselves. They are just going to give us the lab values. So in the lab values, they're giving us all the features of the cirrhosis in the history, and then they're giving us the lab values of AST is 60 and ALT is suppose 29 or 28. So it is almost 2:1. So what does that mean? It is alcohol. Even if the patient is saying, they say that in the history, the patient says that I do not drink alcohol. So, but still, if the AST-ALT ratio is 2:1, then it means that it is due to alcohol. Because sometimes the patients are not going to disclose this. They might be embarrassed or they don't want to disclose it, because if they disclose it to us, of course, the doctor is going to tell them to stop and they don't want to stop. So if the ratio is equal to 2:1, then it is AST-ALT, like alcohol use disorder. But if the patient, they give you a scenario in which the patient says that, okay, I drink regularly in the history, but the AST-ALT is not 2:1, then alcohol is not the cause. Then there will be some other cause. Okay, so they might trick you by giving alcohol in the history, and the ALT-AST ratio might be different. It won't be 2:1. The AST may be very high or very low, less than ALT, then there will be some other cause. And what are the other causes? We're going to discuss them in the chapters when it's going to come. So just remember, for alcohol, it has to be 2:1, even if there's no history. Then in CBC, anemia, thrombocytopenia, we're going to check, and we're going to check INR. Okay, what is the management? Similarly, first counsel the patient, then put the patient on regular follow-up. If he's ready for withdrawal, start him on medication. So 10% of the patient in alcohol withdrawal will have seizures or delirium tremors. And for alcoholic seizures or delirium tremors, we always give diazepam. Okay, if you admitted the patient and the patient presented with signs of seizures, sometimes they do give you a scenario in which they say that a homeless patient was admitted for something. Maybe he was admitted for a hernia repair. Okay, and after 2 days of the admission, what happened? He is now having seizures. So what is the most common cause of those seizures? He has no history, everything is fine. So it might be that he's homeless and he might be alcoholic. So we have to keep these things in mind, that in which population, what thing is common. So he might be alcoholic and he didn't give us the history, and now he's having those seizures because of that. So what are we going to give him for those seizures? Diazepam. Always in alcoholics, we have to rule out, screen for any spousal or child abuse, because when they drink, they are not in their senses and there can be a history of abuse. They are high risk for that. Refer to specialist or inpatient program if dangerous or highly unstable home environment, severe medical or psychiatric concerns, addiction to drug that may require inpatient detoxification, and refractory to other treatment programs. What is the pharmacological? For withdrawals, we are giving diazepam. This disulfiram, it is written in the book, but look, but no longer available in Canada. So we should know that this is not available in Canada. The drug that is not available in Canada, they are not going to ask you. But still, we should know that we do use disulfiram also. But what is more important for withdrawal, diazepam? Instead of disulfiram, we should know we give naltrexone and comprosate. The medications which are written but they are not available in Canada, they do not, they're not going to ask you, or they're not, when they're not using it in practice, why would they ask you? If not, it's not. This test is all Canadian based. So they are going to ask you about the things which are available in Canada, and they expect you to write those things which are being used in the practice. Okay. Then what are the adverse effects of drinking? We have the GI problems like gastritis, dyspepsia, pancreatitis, liver disease, bleeds, diarrhea, oral esophageal cancers, in cardiac hypertension, alcoholic cardiomyopathy, neurologic Wernicke-Korsakoff syndrome, peripheral neuropathy, hematologic, we have anemia, coagulopathy, then we have trauma, insomnia, family violence, anxiety, depression, social family dysfunction, sexual dysfunction, or fetal damage. These are the common. Okay, now we have the common presenting problems in which can patient present with in the family setting. Right now, some of these problems are also in emergency medicine. How to deal them in emergency settings, I will tell you, we will discuss them in emergency medicine lecture, so that I don't want you to get confused. I want you to know right now we are studying about family medicine. So if they're presenting in our office, what is a family medicine setting they will give you? They will tell you in the scenario that they are presenting in the office. Okay, so how will we deal them? So first of all, abdominal pain, very, very important. You should always know the DDs. In all these, the common presenting problems we will discuss, you have to know the DDs. The DDs are very important. They might give you a scenario, and in that scenario, what they will do, they will ask you about the patient is presenting with an abdominal pain and what are the DDs. Okay, what could be the causes? So you should know the DDs. And if you know the DD, then you can diagnose also. If you don't know the DDs, you will not be able to diagnose. Like in GI disorder, what could be the causes? It could be peptic ulcer disease, pancreatitis, IBD, appendicitis, gastroenteritis, IBS, diverticular disease, biliary tract disease, urinary tract disorders, UTI, renal calculi. Gynecological disorders are PID, ectopic pregnancy, and endometriosis. Cardiovascular, coronary artery disease, abdominal aortic aneurysm, and ischemic bowel. Other are DKA, porphyria, hypercalcemia, medications like NSAIDs, alcohol, toxic ingestion, foreign bodies, and these are all the causes. Now, patient can have any underlying cause, and he might just present with abdominal pain. So to exclude these, they will give you one or two another sign or symptoms. Then we have to know, okay, it can be this and that. But what are the red flags of abdominal pain? Severe pain, signs of shock, peritoneal signs, abdominal distension, pain out of proportion to clinical findings, new onset pain, change in pain or altered bowel habits in elderly, weight loss, bleeding per rectum or melena, anemia, supraclavicular nodes, and family history of serious bowel. If the patient is presenting in your office with any of these red flags, it means that it is an emergency and we do not have to just deal the patient in the office. What if he is presenting with signs of peritoneal signs, right? It means that there can be any rupture, there can be any serious underlying pathology. So we won't any obstruction. So we won't just deal him in the office and we're going to send him home. No, that is going to be a red flag for us. And what are they assessing here? Whether we are a dangerous doctor or we are a careful doctor. So always, whenever you read the scenario, do read whether the setting is in the office, in the emergency. If they give you a patient is presenting to you in the office with abdominal pain and has all the peritoneal signs, what are we going to do? Immediate. The answer will be immediate or urgent referral to the emergency department. That is going to be the answer. Answer is not going to be laparotomy or surgical consultation or referral. No, he needs immediate attention. And for that, we have to urgently refer him. Okay. And remember, we have to write urgent. If we are just writing referral to the emergency department, it means we're just referring him. He can go. We are not putting the emphasis that it is an urgent situation. So if with any of these signs, he is presenting to us in the emergency, in the office setting, then it is a red flag and we have to act immediately. If the patient is presenting with he's an elderly and he's presenting with abdominal pain, history of abdominal pain and some constitutional symptoms, it means that this is a warning sign. We have to do some other investigations to screen out any cancer. Okay, in patients age more than 50, keep a high index of suspicion for abdominal aortic aneurysm. Its presentation may mimic renal colic or diverticulitis. Okay, then this, we should also know, if you know this, like the location of the pain, that if the patient is presenting with the pain in the epigastric, what could be the causes? Your life would be easier. So it's very easy. Like, remember, right upper quadrant, biliary, hepatic, colonic, pulmonary, renal. So we will first rule out these causes. If he's presenting with just in the foregut, he says, I have pain in the epigastric, the pain is radiating towards the back, then what comes in it can be pancreatitis, because pancreatic pain is radiates towards the back. So it can be esophagus pain, stomach, proximal duodenum can be involved, biliary tree can be involved, liver can be involved. Similarly, if you say that I have pain in the left upper quadrant, then cardiac, gastric, pancreatic, renal, and vascular causes would be there. So whatever the location of the pain he's telling us, first we have to rule out those causes. Okay, for periumbilical, distal duodenum to proximal 2/3 of the transverse colon. Similarly, for the right lower quadrant, colon, appendix, gynecological, and renal, and left lower quadrant, colonic, gynecologic, and renal causes. And any location, if the patient is saying that it's just diffuse abdominal pain and he cannot locate it, it could be aneurysm, it could be dissection, ischemia, any zoster, muscle strain, hernia, bowel obstruction, peritonitis, porphyria, and DKA. Along with that, remember, whenever a female they give you in the exam that, okay, she's a female, she's of a childbearing age, and she's presenting with abdominal pain. Whatever the history is, we always have to first do beta HCG in her. Abdominal pain or pelvic pain. A female of childbearing age is presenting to you. First investigation we will do is beta HCG to rule out any pregnancy, any miscarriages, any underlying unknown pregnancy, any medical legal case. She might not be telling you, but we have to rule. Childbearing age, we have to first investigation we are doing beta HCG. Okay. And then depending on the scenario, the investigations change. Okay, so what are the possible blood work? CBC, electrolytes, burn, creatinine, amylase, lipase, AST, LP, bilirubin, glucose, INR, PTT, toxicology screen, and beta HCG. Most important is you should always remember for childbearing age, women, pelvic pain, abdominal pain, bleeding per vagina. First investigation is beta HCG. Then This what they have written, this is actually for the emergency settings. We don't have a X-ray in the office setting. We don't have KUBs, where CT scans, ultrasounds, we don't do those. So these are mainly for the, it means that if patient is presenting with any of these pains and has the red flags, immediately we will refer the patient to the emergency. And then in the emergency, what are we going to do? If there is free air under the diaphragm in the setting of perforation in surgical abdomen, we have to do chest X-ray. Abdominal X-ray or KUB, consider gas pattern, free air, kidney stones, constipation. For these, we are considering we have to do abdominal X-ray. Ultrasound for a patient presenting with renal stones, gallbladder disease, gynecological problems, liver disease, pancreatitis, diverticular disease, and appendicitis. And for abdominal aortic aneurysm, appendicitis, non-contrast helical CT scan, we will do, CT scan. Remember, CT scan is never the first right answer. Okay, these are very expensive investigations, and everything over here is covered by the government. So we always have to start with the basics. If they ask you the first initial investigation, start with the basic investigation. Don't just write CT scan. So if they're asking you, like for a patient giving all the signs of renal stones, and they are asking you what one diagnostic test we are going to do, then it can be non-contrast helical CT scan. But if they are asking, giving you a scenario of renal stone, patient is presenting with costovertebral angle tenderness and other history of stone, and they are going to ask us that, okay, what is the next step or next investigation? So we won't be writing CT scan. It is not, we can write ultrasound, X-ray, KUB. Okay, these are the next. But if they're asking only one to confirm, or if they say to confirm your diagnosis, you have performed all the investigations, and now to confirm what is the one test you are going to do, we are going to do this. But never write CT scan, MRIs, these high expensive tests as the first line. Okay, because they are also checking, along with being a safe doctor, are you a doctor who is like considerate about their resources, about money and everything? You're not just who is immediately rushing to the high costly tests. So remember that we have to, here everything is a stepwise approach, so we have to use that approach. Then we have allergic rhinitis. For allergic rhinitis, what the patient will give us a history of allergy. He might have a history of eczema. He might have a history of sinusitis, otitis media. So he will have some history of allergy. Might have a family history of asthma, and he himself never had an attack. So any one of these history, and he will present with the symptoms of rhinitis. So it is most probably allergic rhinitis, and it can be two types. It can be seasonal. He might say that at a specific time of the year, like during spring, when there's grass, weed, trees, pollen. So I have this sneezing, runny nose, red eyes. Or he may say that it occurs all the year. So it can be perennial, all year long, or seasonal, depending on the presentation. Then but there will be a history of family history of allergy, or his own history of allergy. So what then we are gonna treat it, and basically it is a clinical diagnosis according to the history and symptoms. Then we see that, okay, it is a clinical diagnosis. And what etiology is what? Increased IgE levels to certain allergen, excessive degranulation of mast cell. You guys don't need, you should just get a review that, okay, allergic reactions, what is happening, but we don't need to, you don't need to go into the depths of the pathophysiology of each disease or the etiology. You should know, but not the like the pathophysiology, this happened, this cell is doing this and that. They are not assessing you or not checking you on the pathophysiology. In 5 years of that medical school, we learned about it. Now they want to know whether you are able to apply that knowledge in the clinical setting or no. So you should always know sign and symptoms, the investigations, whether it is we have to do investigations or whether it is just a clinical diagnosis. And then what is the management? You should know. These are the things you should know in by hand. DDs for all these topics we are going to do in family medicine. you should know the DDs. DDs are very important. If you know the DDs, red flags, you can diagnose it, and then you can write the investigations accordingly. Okay, for management, what is it? It is conservative management, first line. Minimize the exposure to the allergen, most important aspect of management, and then maintain hygiene, saline nasal rinses. Along with the conservative management, if the patient has a lot of allergy and a lot of symptoms, then we start with antihistamines. And what are these? These are cetirizine, fexofenadine, and loratadine. Intranasal corticosteroids for moderate or severe or persistent symptoms. So we are starting the patient on antihistamine, but still if the patient's symptoms are very severe and they are not helping, then we will only give intranasal corticosteroids. Otherwise, they are not used as a first-line therapy. Similarly, intranasal decongestants, they are not given a lot because of their risk of rhinitis medicamentosa. And what is rhinitis? If they are given just for 4 days, less than 5 days means 4 days, up to 4 days, but they are not given. So first line treatment is antihistamine, intranasal corticosteroid if not working. And because they have the intranasal decongestants have the risk of rhinitis medicamentosa. And what is that? That it develops a kind of a tolerance. The more you use, the symptoms are going to be more, and more you're going to need the same drug to relieve your symptoms. Because of that, like rebound nasal congestion occurs with prolonged use, more than 5 to 7 days of vasoconstrictive intranasal medications. Patient may become dependent, requiring more frequent dosing to achieve the same decongestant effect. So it is just going to exaggerate the symptoms, and the patient is going to use more and more to relieve the symptoms. So the first line is conservative, along with that antihistamines, and then intranasal. And it is a clinical diagnosis, okay? If they are giving, we do not have to do any tests. We will, with the history and the symptoms, we will assess that, okay, it is the patient has allergic rhinitis, with the physical examination and everything. Then amenorrhea, we're going to cover it in gynae. Similarly, for anxiety, it is going to be covered in psychiatry, but we will go through this table. So how will we screen the patient for generalized anxiety? What are the screening questions? Do you tend to be anxious or nervous person? Like the patient is presenting to us with anxiety, with symptoms. He says that, okay, I remain anxious all the time, or I worry a lot. So we have to ask him these questions. Or maybe he presents to us and he says that for the past few months, what happens, all of a sudden I start sweating, I have palpitations, and I feel dizzy, I can't breathe. Then to screen it, whether it is anxiety or no, we have to ask him these questions. Do you tend to be anxious or nervous person? Do you have you felt unusually worried about things recently? Or has this worrying affected your life, and how? And after this, we should know there's a DSM-5 criteria, which is written for each topic separately in psychiatry, which we're going to do. If you know the DSM-5 criteria for each, then you will easily be able to differentiate. In the MCQs, in the CDM, you will be, if you know this criteria, then you can differentiate, okay, this is depression, this is schizophrenia, this is that. If you don't know the criteria, then it will be different. You will always stay confused that, okay, it's more than 1 month, less than 1 month, because according to the criteria, the diagnosis is changing. So if the patient is presenting to us with the symptoms of anxiety, okay, and what are the symptoms? I think they were written. Yes, here are the symptoms. So yes, here are the symptoms. If he is presenting with anxious, nervous, or worried, no control over the worry, duration more than 6 months, irritable, concentration impaired, restlessness, energy decrease, sleep impairment, tension in muscles, he is presenting with any of these symptoms, then we have to see that what is it. We will go to the next step. For that, are the symptoms in the form of panic with autonomic symptoms? Like, do they occur all of a sudden? And along with these, does he have any autonomic symptoms? What are those? Heart rate changes, sweating, restlessness, palpitations. Like all these are the autonomic symptoms, any fainting episodes like dizziness, feeling dizzy, nausea, vomiting. So if do the panic attacks come all of a sudden out of a blue, he's just sitting and he has those attacks, and then now the patient is afraid of having the next question we're going to ask him, that are you afraid of having another attack? If he says that all of a sudden these attacks occur and now I am scared that they will occur, so what is this? It's a panic disorder. But if the panic attacks occur with a specific situation, he tells you that they are coming with a specific situation, then is the patient trying to avoid the situation? Then they can be phobias. There are different type of phobias. According to that, we are going to ask the patient, like, what is the situation they are avoiding? And in what situation do they come? Is it like people have phobias from heights, spiders, flies? So it could be a specific phobia he's having. And because of that phobia, maybe he's experiencing frequent exposure to it, to those things. And because of that, he's having again and again the panic attacks. So it could be a specific phobia. If not, are these things occurring in any public settings? When he goes out in public, he's going out in office, do they occur in there? If then that it is social phobia, and is he avoiding the public settings? Then settings where may be difficult to, some people are scared of closed spaces, in lifts, in crowded spaces, they're scared of going in buses, that it might be difficult for them to escape. So it is panic disorder with agoraphobia. So depending upon the setting, the diagnosis will change. See how it changes? Above, the symptoms will be the same, but our next question and the presenting complaint, according to the triggers, it's going to be the diagnosis is going to be this different. Similarly, if the symptoms are occurring after some trauma, now if the trauma, it has been less than 1 month, then it will be acute stress disorder. Okay, remember, if the symptoms are occurred, maybe the patient experienced some accident, he saw somebody in an accident, and after that 2 weeks have passed and he's coming to you and he's complaining of these symptoms, then it is going to be acute stress disorder, acute stress reaction or disorder. Then if the same symptoms, he is saying 1 month has passed, less than 1 month, it will stay acute stress reaction. But if the same thing is continued for more than 1 month, then it will change into post-traumatic stress disorder, PTSD. Less than 1 month, acute stress, and more than 1 month. He's coming to us after 2 weeks, we will say, okay, you have acute stress reaction, we will treat accordingly. But he's coming to us after another 2 weeks or 3 weeks. Now, how much time has passed? More than 1 month has passed, and the symptoms are persistent. So it is PTSD now. Then if the patient is having recurrent anxious thoughts with it, are the thoughts about worrying? He's all the time worried about what is going to happen in the future. What is he going to do? If they are, yes. And along with this worrying, there is some stressor. Like he recently moved to some hostel, to some new office, to some new city. And after that, he's having all these anxious thoughts. Then it is adjustment disorder. But if they are present for less than 6 months. Similarly, if these worries and thoughts are present for more than 6 months, he's continuously worried what is going to happen in the future, how I'm going to, about his financial life, about his family life, anything could be there that is worrying about him and is affecting his life, then it is generalized anxiety disorder. Okay, and then if he's not worrying about this is not the excessive worry, but he's aware of it and he's having recurrent thoughts. And he's trying to avoid those thoughts. And to avoid those thoughts, he's having a specific type of behavior. Then it will be OCD, obsessive compulsive disorder. But excessive worry and apprehension about social situation, if the thoughts or the worries is just about social situations, then it is social phobia. Okay. And remember, management for all these disorders, most of the conditions in for mood disorders, for other disorders in psychiatry, first line treatment is CBT. Always first line is we start with CBT, if CBT, and the best is CBT. Okay, if it is not working, the psychotherapy, cognitive behavior therapy. If it is not working, then we move on to the next step. So remember, first line, if the patient is coming in the office setting and they tell us that, okay, what is the first treatment option? We will say we are going to start with CBT. If they give us the scenario that, okay, even after CBT, it's not working, what is the first, then next step, then we will move on to the pharmacotherapy. Okay, so educate the patient, psychotherapy. Psychotherapy, including CBT, exposure therapy, relaxation therapy, all of these come under psychotherapy and CBT. They're different according to the different presentation. But even if you're just writing CBT, it covers all of these. And we will educate the patient like about regular exercise. If he's taking a lot of caffeine or alcohol intake, then reduce that and collaboratively develop a person-centered plan. Okay, just let me. Okay, it's almost. Just pause here.